Hello. For those of you who don't know me, I'm Dr. Boris Pavlin. I'm a field epidemiologist. I work for the World Health Organization, and I'm one of the co-founders of the aFETPNG program. I came to the WHO office in PNG in 2012, and in that year, Barry, Dr. Bieb, colleagues from US CDC in Australia, and others agreed on an ambitious plan to create a field epi training program in PNG that would train top-notch epidemiologists in all 22 provinces and eventually all districts. It was also one of the first and only programs in the world to insist that the projects have a direct impact and that those impacts be measured. Most people thought we were crazy, given the way most VTP programs start small, with maybe half a dozen fellows and a very modest curriculum. But Dr. Bieb and Barry had a vision, and I'm happy to say that since 2013, aFETPNG has just grown from strength to strength. I can say with total certainty that my involvement with the program was the most meaningful and impactful aspect of my 5 years in PNG, and probably the most meaningful professional activity of my career. In the time since I left PNG in 2017, I've continued to watch the program from afar, and I was again amazed when I heard that aFETPNG was embarking on an advanced course in 2019. Again, something most people would have thought crazy, given how recently the intermediate program had begun, and even more crazy because it enrolled in its first year 18 fellows, a number unthinkable to even many fully mature programs. To give you an example, the entire European Union's EPIET international program is only about that big. Add to that the complexity of doing virtual learning, and aFETPNG truly has continued to be a world leader in this field. I've also taken great pride in some of the groundbreaking work by aFETPNG fellows, much of which has been shared on the world stage at TEFINET conferences and elsewhere, such as when we went to the Cambodia TEFINET conference and we had 6 presenters to Australia's 1. Today, I congratulate you, the 17 graduates of this amazing program for the year 2022. It's great to see so many familiar faces. I had the privilege of training some of you, about half of you actually, for the intermediate program. And it's also great to see old friends amongst the trainers and to see several of you giving back to the program as faculty. I hope that each of you graduating today will continue to give back to the program in one way or another. You've already had a tremendous impact on the people of PNG, and your work is being recognized. For example, in the creation of new positions around the country, such as Bob's field epidemiologist position in the Eastern Highlands. The skills you have learned in this program have prepared you to be the leaders of public health in PNG and beyond for many, many years to come. Good luck to each and every one of you, and congratulations once again. This is your day.
I am exhausted. We're all exhausted. The last few years has been really hard. This is what we do. But I don't think I'd ever considered how hard it would be to be in a response mode for so long. We never practiced scenarios where our colleagues were dying and our family and communities were so impacted. Much of the world seems to think that COVID is over. But not only is COVID not over, we are moving from one pandemic to the next. A pandemic of secondary health and social impacts arising from COVID. Progress made on important public health issues like TB, HIV, and malaria has been slowed and even reversed. Already fragile systems weaken further, and already overworked workforce stretched even further. But we are still here. We will continue to press on. Our communities need us now more than ever. We are responding and rebuilding.
We are strengthening routine immunization program for our children.
We are working to make sure pregnant women have access to the support and services they need.
We are making sure our patients have access to frontline care and life-saving medicines.
We are preparing the early warning systems to detect disease outbreak and training teams to rapidly respond to them.
We are conducting research and analyzing data to guide our decision making. We are training our co-workers and colleagues on preventing and responding to disease threats. We are sharing information and coordinating activities across the human, animal, and environmental sectors. We are building relationships and trust with our community leaders. And of course, we are continuing to respond to the biggest pandemics we've ever experienced and prepare for any others that might be coming. And we have got a lot to do. Thanks to everyone who support us and the work we do.
Thank you, Alice, and thank you for graduates, our friends, aFETPNG faculty members from Australia and those who are tuning from around the world. And actually, we have some people at the tuning at the virtual. Thanks for our invitees, guests, especially from the provinces. I can see that the monitoring evaluation representatives here as well. Thank you for coming. Our good friend, Rachel, thank you for coming in. I think for this presentation, I will just give an overview of what aFETPNG has done and how we have started training and where we are now. So bear with me. Okay. This is the background. We started with the 9-month training program, which is called intermediate. Since 2013, and we started the 2019 with advanced program, 18-month program, which is the first for PNG. And we are in the process of starting our 3-month program, the frontline, which will include all the that focus on the frontline at the health facility, hospitals, and also our partners out there in the provinces. We're also taking part on the rapid response team training. I know there's been some rapid response team training called happening in the province through the NCC. This is quite different. This is a comprehensive RRT training. It's not specific to one disease or one particular situation. We also involved in a leadership training. At first, when I started the aFETPNG training program, I for myself I thought that I was going to do aFETPNG training just to do surveillance work and improve outbreak response. Now, that's not the case now. After cohort 8, we are into our cohort 8 now and 1 cohort for advanced. We have changed from what we thought initially to what we are now. We're doing more than just surveillance and outbreak response. That message must be very clear, especially to my deputy secretary and my executive manager and other program officers here, that it's not just surveillance and immediate response. We're also involved in the faculty development. That means that we try to sustain the training program, so that we then be able to lead, facilitate, and be able to sustain the program, I think, for many years to come. Because this aFETPNG training is not just one-off workshop kind of training. It's a skill-based training program for our workforce out there. We also train them on operational research, very essential part of our officers there. We have high-class, highly named people in the province, like directors and deputy directors and program managers from national level down the line. But do they know evidence? Do they know about having the evidence to make a decision, to distribute resources based on evidence? The operational research skills will then be able to help us to determine that. That's why we are teaching people to do operation research, wherever they are. And we are doing also ongoing professional development. So the wheel that you see probably our graduates have it at the back is a new vest that we have developed. In particular, with the changes we're building that, so that people can then be able to visualize what we are doing in aFETPNG training program. So it's a list of activities to strengthen public health workforce and strengthen health systems. So there you are, health systems. The department talks about whatever we do is to strengthen the health system. aFETPNG is strengthening the health system. It's not for surveillance and emergency response, where many people in the department think, or many would think in the provincial level. So it's a long-term investment aiming for transnational impact, and it's a global recognition of regional leadership training program. This is the group, the advanced heavy training, the first one in PNG. We started with 80 or 20, or sorry, 30. We lost some on the road, and we probably then end up with 18, and we lost one, and we're now to 17. So the 17 now only here. So the advanced training it was prioritized workshop. I mean, representation from NDO, WHO, and PHAs. It was established priority teams and key operational areas. Comments in 2019 November. The 4 teams each focused on priority team and addressing key areas, and at which you can see on your right hand corner there. Sorry, that's training post and support for provided for during the COVID was we did visual sessions, we did webinars, we also sent out IFC materials. We also did a swabbing study, vaccination estate study, which was presented in the medical symposium by Mata. We also did a leadership training for Vichel, and we did take part in RRT during the COVID lockdown. So the project, because of the COVID, there was a pause on the training program, and but during the pause we continued to that engagement through virtual training and virtual communication and mentoring. So we started the project in 2021, and the second face-to-face workshop commenced in 2022, and here's the third final one. The second one was in April, and we have the final one now. And this is a new one. We had a policy prepared by fellows. We had our good faculty member and Dr. Gilbert Yawala lead his team with the what do you call this? The vital statistics to come into Waitaki. They were there for 1 week, and this is one additional training skills. And I missed that, but I think according to the participants, they think that they need more in that part, and the faculty will think about how we can be able to do that in 2023. So I think that was a very, very interesting one. Okay, the content of the advanced aFETPNG include the outbreak investigation. It's more advanced, additional to the intermediate 9-month program, and they also take part in surveillance evaluation, field epidemiology methods, operation research again, intervention of the projects, data management, descriptive and analytic data analysis, using data for decision making, Excel and Power, field EPIs, policy development, monitoring evaluation, community engagement. Again, this during the COVID, as well during the training, this is very, very important area in terms of our business of response to outbreaks and disaster management, risk communication, leadership skills, and more. In terms, this happened at Waitaki. Policy development is data to policy. We've done data collection, analysis, we've done operational research, we come up with outcomes and also the recommendations. It must link with the policies. If we don't have the policies, this will help us to maybe develop new policies. So as I said, it's a new area we have touched, and we want to make sure that we continue to develop in that area for our fellows. Okay, and the highlights in 2020, we did a swabbing study, provided recommendation for increasing swabbing for COVID-19 in PNG, in collaboration with aFETP training, NDOH, NCC, WHO, and St. John's. And it's published in the peer-reviewed journal. Also in 2020, after action review with NCD Rapid Response Team, established to improve RRT effectiveness in response. Key areas identified for future RRT training in PNG. Also in 2020, Advanced aFETP was involved in COVID surveillance evaluation. Provide recommendation on strengthening COVID-19 surveillance in PNG. In 2021, we did a vaccine escalation study, demonstrated healthcare workers are the most trusted source of information for public health. It was done through aFETP, NDOH, WHO, St. John's, and UN report. In 2021, rapid response team training initiation trainings. These are 2 to 3 days training done, and also we've start off with oral with visual, and then we did a follow up again in face to face. Gulf, ARB, Western Province, Morobe, which Emmanuel is the rapid response team training coordinator. I employed through World Vision program financed by WHO. I think we are now up to what, 14 RRTs done so far. This is the initial 2 to 3 days. After we complete all the provinces, we'll start off the comprehensive 1 week WHO curriculum based, but revised to suit our needs here, starting next year after we've done the initial training. We've done a couple of after training reviews. How many, Emmanuel? 5. We've also developed the RRT e-modules for e-learning. In 2021 as well, 5 RRT e-modules developed. That's introduction to RRT, outbreak investigation, preparing for field investigation, conducting a field investigation, and follow-up post-field investigation. In 2021, the Intermediate Field aFETP CFON accreditation, United Nations Institute for Training and Research. We're proud to announce that we have been recognized. That means that we will continue to get the kind of support that we can get internationally, and also the international partners here in PNG. And I think that was a great achievement for us. And we know we're here to stay. We're not going to go away. I think also we have also recruited a team to support the aFETP director, which is me. I've been very proud of that director. And which is Betty Smuggy here. She's the convener. And Diaola, she's not here, but she's in our program office or somewhere. Always the program assistant to Betty. And we've also got Abel Yamba, who used to be with the CDC at the US Embassy here, but he's working part-time somewhere else, and also he's got this part-time with us as well as a consultant for the frontline training. So that's the team of aFETP staff, external funding support, but supporting me to me over the aFET training program. Also in 2021, aFETP Internal Ethics Review Board established and approved by MRIC. This ethics committee is a sub to the main ethics committee, which is review what our fellows are doing and make sure that they meet all requirements before it goes to the main body. So that has been already approved by MRC, and that's another achievement that the aFETPNG, I think it's first, as far as I know, for any sub-program or any division or any organization in health ministry to have a subcommittee like that. Am I right, my brother at the back? Yes, he's nodding, yes. In 2021, aFETPNG invited to present at the 10th Southeast Asia and Western Pacific Bioregional Definite Scientific Conference, Field Epidemic Training Development Strategies. We did that through virtual. And in 2021 also we started a new, after we delayed due to COVID-19, the intake for 2021 and 2022. So at 2021, we had 9 new intermediate fellows, and we had them through the virtual training, sort of introduction to using Zoom. Many of our workforce out there in the rural facilities, I guess also in health department as well. I was never used to Zoom until COVID came around. And we, went through how to use Zoom, to have meetings and, training. So we did that, and the introduction to the intermediate aFET training program. And we also had an introduction on public health surveillance system and outbreak investigation. Right. And also in 2021, we were engaged with aFET fellows, also virtually. These are the thematic groups that we have, the advanced aFET group. So we have a group that has taken the project on health systems training. We have a group that has taken the project on maternal and reproductive health, vaccine preventable disease, and communicable disease, including COVID-19. So we have 4 thematic groups in these advanced training programs. And 2021 professional development. Betsiba has attended the World Health Organization infodemic course. Gilbert, when he was with us, also attended the Thailand aFET mentorship training. Abel Yammer and Alice Pavilion, one health interactive course at the human environment and one livestock interface for the Pacific. And we had also senior and junior faculty transnational leadership program. And I think this is again another very, very interesting training program where we have an epidemiologist, I guess, a doctor, turned out to be a trainer, training health workers to become trainers, to train other health workers. And aFETP is probably looking at how to best utilize that person again, not only for aFETP, but also program managers in the department and as well as in the provinces. In 2021, we have a new frontline aFET program. We have a second flow funding for pilot project in 6 provinces, engagement with multinational and international partners, focus on surveillance outbreak response and the community engagement using One Health approach. Engagement and integration with village health assistants. We have had a couple of discussions with Billy Pagi, but now I understand that he's moved over to Central Province, and I don't know what's going to happen in terms of the leadership in this village health assistant program. And in 2022, we have the face-to-face workshop. It commenced in 2022. We have interaction review conducted with fellows for COVID-19. Disease surveillance review conducted by fellows. Policy briefs prepared based on intervention projects. Okay, this is another achievement for aFETPNG. aFETPNG became official member of WHO's Global Outbreak Alert and Response Network in 2022. Access to Guam training and opportunities to mobilize internationally. International recognition of aFETP. Locally, we have done mobilization already. aFETP graduates has been mobilized to other provinces in the last in polio outbreak response. And, we will continue that internally in PNG. And, from that experience, and after being certified, getting the training, then you have to pass the go-on training, and then you'll be ready to be deployed internationally. We just attended the aFETPNG Global Conference in Panama, 7 representatives, strategic partners, meeting with Vanuatu, and we met our friends from Vanuatu and Timor-Leste in Panama. We had a fruitful discussion. They learned that we have trained the Solomon Islands 2 fellows here, and they now kickstart the aFET training program over there. They will be sending their candidates, maybe 2 or 1, depending on the funding, and maybe next year. And then they want to start the program after they have the graduate over there in the country. They will come with their own faculty members so that the mentorship can be done. Okay, thank you for being patient. So I continue my presentation. In 2022, in intermediate aFETP and also frontline, we had a recruit of frontline staff in West Britain. That's 2 officers. In Sundown, we've recruited 1, and we're still in the process of recruiting second person for Pacific. We will develop the frontline curriculum, launch of the frontline in West Pacific and West Britain done, continuation of intermediate aFETP in 2022. In terms of RRT, I think the multiple RRT initiation training is completed. After action review is done, started all 22 programs by the end of 2022. Phased approach to RRT accreditation after the in the 5-day comprehensive training. I think this is critical because it's part of the what do you call build our capacity in terms of getting people on board for a one. Where we see people who are good leaders in the RRT, we can even potentially help them to be part of the one training. Okay, looking ahead in 2023, we're going to continue the intermediate training. That's cohort 9. We started late in 2022, so we're going to graduate them sometimes in March next year, and we start our 10th cohort in April. And we're going to do an inclusion of fellows from Vanuatu and Timor-Leste, expansion of frontline in 4 new provinces, which will have 10 total 6 provinces. Definite accreditation of the intermediate aFET training program next year, 2023, hopefully. If we meet all requirements, I think we're progressing. There's ongoing trainer for senior and junior faculty members, ongoing professional development for graduates and faculty, master teach intensive workshops, and executive training developed and piloted. There's a 5-day RRT competency-based training program implemented. Some of these activities are not, in some countries, aFETP doesn't take it on board. But in PNG, aFETP is taken on board. There's capacity building and system strengthening for our workforce. So there's ongoing engagement and support for aFETP alumni. We have 96 graduates plus 2, because 2 is International Solomon Islands. In total, it's 98. So there will be ongoing mentoring, joint operational research, surveillance system strengthening, support for outbreak mobilization, strengthening of sub-regional aFETP networks. We've had a discussion to do advanced aFETP training in a sub-regional level instead of country-based. So we take the top cream of the intermediate in each of these countries, Solomon Islands, Timor-Leste, Vanuatu, hopefully Indonesia, so that we have We have advanced training at the regional level, sub-regional level. So we have already discussed it, and we will continue to have that in progress. All right, that's the end of me. My name is not there. So thank you for listening for my presentation, and I hope, especially for those my deputy secretary, and for those who are our guests, maybe give you some background on what aFETPNG is doing, how far we have done, what are things that aFETPNG is doing, and so that you can be very informed person to support this training to continue. Because this training will not go away. Yesterday we had, just to close off my presentation, we had 2 ladies from the training division come out and listen to the presentations, where every of these 17 people presented yesterday here, and they were very impressed. The very first question they want to see is which our ambition as well is that we want this training certificate or whatever paper that we give must be recognized. And we were happy to see them come here because we wanted to come and then see for themselves the quality, the outcome of the training, so that in the future along the way, when we decide to house this somewhere, with partnership in terms of delivering this training in a university, they can help us to get our registration down to the higher education in education department, so that certificate or the paper that we offer, whether it be certificate or a diploma or master's program in epidemiology, can be recognized and is a category of health workforce in Papua New Guinea alone. Right. At the moment, which has been housed at the Department of Health, we're happy with the way we are going because we want to grow in it. We want to make sure that we master in it, and we also have to develop the faculty so that we can sustain it. That has been our view with Dr. Biak. And I think we are doing the right thing because if aFETPNG training is academic based and goes to university, I think we will lose the content, the purpose of this training program. So I think but I can say that we're happy that they were there to see the kind of training we're doing. So in the next maybe few years to come, we will see how we can be able to see where is the house properly, so that we can be able to share the resources, our resources, but the leadership, ownership, it must be still the health department. With that, thank you very much, and I'll hand over to the next president and chairman.
Thank you. Thank you, Barry. This is the overview of the aFETPNG program here. Yeah, okay, we'll just continue with our program. Next part of the program is thematic presentation. Our 7 advanced aFETPNG fellows have done 5 thematic areas. Before I invite them to actually do the presentation, I'd like to acknowledge the Australian team who are also remotely listening into this graduation. So I'd like to acknowledge Dr. David Tam, who is also listening, and field epidemiology in action trainers and members who are also listening up there. So I'd like to acknowledge their presence as well. Now we will go straight to the 5 thematic presentations. We had the presentations yesterday, and we cannot have everybody, do the presentation here. So we decided to actually ask 5 fellows on behalf of the graduates who are here, as well as the faculty. Would like to invite them to actually come and present on the 5 thematic areas. The first one to actually come and do the presentation is Rosalind Cardona from the Executive Director of Public Health from the Autonomous Region of Bougainville. We'd like to invite Rosalind Cardona to come forward.
Okay, good morning, everyone. I will be presenting on the project which I implemented back in my province. And the title was to assess the benefits of supervision, monitoring, and feedback to improve immunization coverage in Buka District, North Bougainville, from May to August 2022. That is my background. All of us know that the health systems in PNG are fragile, and the efforts to improve these systems are still challenging. We have the rural health facilities, they have poor access due to some factors like bad road condition and challenging terrain that is in PNG. Other issues that affect our delivery, insufficient training, lack of proper incentives to motivate staff, and lack of medical supplies. In the SPA report from 2016 to 2020, from the last 5 years, it has shown a decline or maybe some little change in our indicators. So I was doing my project was on health system strengthening, and there are barriers to that, and some barriers that we look at are availability, accessibility, affordability, and acceptability in our health system. My goal was to improve supervision to enhance management support for frontline healthcare workers or healthcare services. This is the method that I used for my study. It was cross-sectional, observational, and descriptive. My study location was Buka District, North Bougainville. The participants, we have 5 health centers, but I was only looking at 2 health facilities. That's Hanghan and Demarmano. The sampling method was non-probability and capacity sampling. I had to review the records, university records, clinic site registers from January to August 2022. The analysis was done using Excel, and I was able to come up with the graphs and the tables from that Excel analysis. My public health interventions from the study, the main intervention was supervision, and I had to look at 3 key areas. One was management and coordination support for implementation of immunization program. The second one was regular monitoring of the program and regular feedback to the 2 facilities. The time frame was from May to August 2022. My first intervention, I was able to assist the staff to plan for clinics and access funding, organize the clinics to be conducted at the airport. We have 4, 2 in each health facility. When they were not able to go out for the clinics, they gave these vaccines to the health staff, and they were able to do that at the airport level. Encourage the use of clinic site registers to register all children under 1 year, and to monitor vaccine stocks and ensure that they were available. That was the first intervention. Also this conduct 2 on-the-job training for the health staff. The training was to teach them how to calculate the underworld target population, to monitor the program using the chart, and to encourage the vaccine management, to encourage them to use PHCP PHBs to mobilize the community. Second intervention, regular monitoring of the program. From that training, the staff were able to calculate their coverage, use the monitoring chart to monitor the program coverage, and they were encouraged to implement the program. Third intervention, regular feedback on the coverage. You know, our health workers, they submit a lot of data, but they don't know how to, calculate the coverage and give feedback to know that the program whether is working well, whether they're achieving their targets or not. So they were able to do that. Feedback reports were given through the phone every 2 weeks, And then monthly, whilst doing the visit, I was able to also give them the feedback. And also look at some of the clinic sites where they can do mop up if the coverage was low. My results from the visit, the phase 1 staff was motivated and demoralized. There was no proper supportive supervision visit. There was lack of regular mobile clinics. The staff did not know how to calculate the target population and the coverage. No regular vaccine stock management done, and the vaccine register, which is very important, was not updated. During that visit, I also found out that MR vaccine had expired, and they were still using the vaccine to vaccinate the children. So during that visit, we had to remove the MR vaccine. And the coverage of, for the two facilities was actually low. This is the table pre-intervention. The coverage for Penta 1 was 62.4. For the dead dose, it was 46%. For Level 1, it was 14.7. For Penta 3, it was 18%. And our target, the national target is 95%. My intervention results. I was able to conduct 6 focus visits, give a feedback to them, 10 feedback given, program monitoring 10, and the trainings, I did 2 trainings. This is a graph showing my intervention. That was, I went in May, and as you can see from the graph, the 2 graphs, there was an increase. There was an increase in the coverage. Why was that? Why was there an increase? I see that effective and supportive supervision is very important. So sometimes we just go the way before, yeah, and then we forget about this before. We don't want to visit them. We don't see what they're doing. We don't give them feedback so that they're able to monitor their program. So I believe from this study, effective supervision, supportive supervision is very important, and it has had an impact on the coverage. Regular supportive supervision and program monitoring had a great impact on the university program. The study also showed that program management, monitoring, and giving feedback to healthcare workers can really motivate them, and they will give you the result that you want for your program. And there were some issues that we needed to sort out once during the visit. So sometimes they have issues, but that there is no one there to help them. So during the visit, we were able to sort out these issues. These are the benefits and outcomes of effective supervision. So showing that it is IM3, 1 year, it supports professional practice and reflection. The second one is it supports continued personal development, and also this better patient or program outcome. It improves the work environment, the culture, and also it improves our well-being. My limitations, we were only given 3 months for the intervention, so it was, I only selected 2 facilities, and this was going to be representative of the true state of our program. This was a non-provocative study with requested sampling, and the chances of introducing bias is high. I was not able to use the study designs and sampling method because of time limitation. My recommendations. The first one is regular supportive supervision and monitoring the program is mandatory and will be continued in the other facilities. Training of healthcare workers is also considered a high priority to improve staff knowledge. Establish and strengthen the use of API monitoring tools like track, effective program implementation, and roll out the visit in the other 3 facilities in Bhopal. My next step for action. Present the results to the Ministry of Health and the district staff. Consult with the stakeholders on my policy brief to address the problem. Carry out further studies to improve the health system strengthening to enhance program performance. I would like to acknowledge these people who have really helped me with this project. And as you can see, that's a photo of the volunteer health community program village health volunteers. Thank you.
Thank you. This is the first presenter. The next presenter is Mr. John Latimer, who will come and do the presentation on his thematic area. Thank you.
Thank you, Alish. Good day to you all. My project and my intervention project was on establishment of respiratory clinics to improve rapid diagnosis and reduce transmission risk within outpatient in our district, August 2021 to 2022. So these are the respiratory clinics that I embarked on during the COVID-19 pandemic. It's really challenging. And this was the COVID-19 funds that were given to the district. I used that money to try creating that to address the issue of COVID-19 and infection control. So as we know, respiratory disease can be highly infectious, and transmission of infection between patients and staff with overcrowded outpatient department is a major concern. So diseases like ILI, influenza, TB, and pneumonia are still a problem in the district. In 2021, I did operational research and found that 80% of the attendants were coming with cough. And they were lining up in the outpatients, and the transmission was very high. So I created a clinic to divert them from the health center, and keep them screen them in a place that is suitable for them. So COVID has highlighted the importance of separating patients presenting with respiratory symptoms from other presenting for care and treatment. So my goal was to establish 4 respiratory clinics adjacent to the health centers to divert cough patients away and to improve infection prevention and control, reduce transmission and improve diagnosis of respiratory infection. So the picture on the right is one health center respiratory clinics, and there's a little makeshift waiting area. On the other side is Bua. It's in the coast of Nawa district. That's the waiting area. That's the old respiratory clinic. So the study was the intervention was done in Torowa Health Center, that is in Ewa, Bua Health Center, that is in Labuta, the coast. It's Situ, it's out of Lake City, and Buana, the headquarters of the district. So all patients presented to the respiratory clinics were monitored over time to assess demand and accessibility by the community. Symptoms, testing, and diagnosis of patient actually the respiratory clinic were recorded and reviewed. And IPC practice of staff in respiratory clinic were observed. So data from respiratory clinic registered were captured in Excel line list. And I also did observations and notes on IPC use by the staff. Outcomes measured, number of patients attending the new built respiratory clinics over time, symptoms of patients presenting to respiratory clinics over time, observation of staff effectively applying IPC measures at the respiratory clinics, number of specimens taken from respiratory patients for laboratory investigations, and number of tested positive via COVID or TB. So this is a graph showing the attendance of respiratory clinics. So we have a high attendance. So you can see that's according to sex, as male and female. And then we have a high number from April to May. Then June we have the election. So kind of people were busy in the villages with the candidates and so forth. The graph there shows the sex. There's equal number of male and female attending the clinics. And on the other side, other graph is the age category. We have a high number of children because the parents are brought into the health center, into the clinic. But collectively, you can see there's a big number of adolescents and teenagers. So there's increase in patient presenting from mid-May to mid-June. Case presenting to the clinic declined in July, as I mentioned, of the election. The even number of men and women accessing the clinic over time. An increased number of children were seen to be taken to the clinic by their parents. However, collectively, there is a high number of attendees that are teenagers and active mobile population. So this is patient presenting to rescue clinics with cough. So you have the cough on the red, the green are the other symptoms. Patient with cough presented to rescue clinic instead of health center are likely to release cough better and improve infection control. However, a large number of non-cough patients did visit the respiratory clinics. When they come, there's an outpatient there, and then there's the respiratory clinic. But due to some the availability of staff, the manpower, and the outpatients, and if there's a staff at the respiratory clinics, then you have people lining up at the respiratory clinic rather than going to the outpatient. Specifically without the cough, their predominant symptoms were fever, headaches, skin sores, and general body aches that were seen. In observation of the staff using PPEs for infection control, after the training, I did some training in the district. Gloves sometimes used. Gowns that both were already used by staff attending to patients. The gumboots that we bought for the respiratory clinic were not used at all. Masks were sometimes used. Initiate hand washing for patients that enter the clinic. Sometimes staff initiate, sometimes we forgot. Hand washed by staff in the busy and rush. Then they wash their hands after attending to patients. And waste disposal, daily waste disposal was not done properly. So an increase in the overall number of clinical specimens taken from cough patients was noted after the establishment of the respiratory clinic. In 2021, with the extended the outpatient department, 12 cases were investigated for TB and 3 were positive for TB. After establishing the respiratory clinic, we began to segregate cases cough to respiratory clinic. We got 51 cough cases. Out of that, 5 were positive for TB. So it's a 325% increase. So we found TB there. So demand for respiratory clinics was strong until July 2022 as the election grew. Most people were confined to their village and were not accessing health services. Clinic was accessed by men and women. Children are vulnerable to disease and so have a high number of attendees. Cough patients present at the respiratory clinic instead of health center. Many non-cough patients were accessing the clinic. Further work is needed to let the signpost and further initial training, prioritizing, community engagement will also help clarify the role of the respiratory clinic. And further staff training and enforcement IPC measures is required at the respiratory clinic. There are some limitations. There is still stigma associated with COVID-19. Therefore, anybody that accesses the respiratory clinic is seen to have COVID. The election period also affected attendees to the respiratory clinic. And during the time of the intervention, you see just of 4 respiratory clinics. Actually, BOA was not really operating due to staff issues and also situ. Recommendations: ongoing operation of the respiratory clinics is recommended with ongoing monitoring of usage. Better signs indicating who should go to the respiratory clinic and who should go to the health center or the outpatient. And community engagement initiated to reinforce the use of respiratory clinic. restricted pricing at the respiratory clinics to ensure only respiratory patients are seen. So we do direct patients, cough patients to the respiratory clinic. Penetrating and enforcement of IPC measures by staff and patients at the respiratory clinic. Next step for action. To consult the district office. The district has been really supportive for the project during the heat of the COVID-19 pandemic. So I have followed a policy brief with three policy options. One of the policy options is to maintain and strengthen the respiratory clinic to be a standalone facility in the health center, issue of respiratory infection. And then engaging with the district administration and political office to advocate an intervention to sustain the respiratory clinic. So thank you. These are the trainings that I've done in the districts during the COVID-19 pandemic on IPCs in Situm, Buana, Torabua. Thank you.
Thank you, John. The next donor to come forward is Dr. Mary Kawakore. Thank you.
Good morning, everyone. My intervention study was based on evaluating the use of the COVID-19 data collection app amongst healthcare workers in NCD. The study was from May to June this year. We all know that COVID-19 pandemic is not over yet. So with that, we know that it is still going to be a public health threat for us. So by now, there's about over 1 million COVID-19 cases. In PNG, as of the 147 seat report from NCC, we have about a cumulative case of 44,912 and 664 deaths of COVID in PNG. My operational study, initially done back in August 2021 to September, from that study, I found that about 86% of clinics in NC did not have a proper testing site process for reporting COVID-19 data. Back then, I was the surveillance lead, so I carried out the study during that period. So with that, the current NCD reporting system is paper-based. So what happens is that the COVID-19 surveillance reporting, when it's paper-based, it tends to lead to delay of reporting and response to prevent transmission, and then so we have increased number of deaths of COVID-19 cases. So what was my intervention goal? So for the intervention goal, I wanted to see if we could improve timeliness, completeness of COVID-19 data reporting through introduction of an app which we came up with the help of my IT officers. So the app was a COVID-19 data collection app. So it is mobile. It's a mobile app. So as you can see on the screen here, that's a background of a mobile app. And then this is the app, and it's called a COVID Ops app, and it's used on Android phones. So what is it? It's user-friendly, a data entry app. It allows all clusters to enter data. It has its security features. It has a unique password, username, and the compatibility and requirements. It can be used only on Android version 5 phones and tablets. The objectives of the intervention was we wanted to review the current reporting system pathway in NCD clinics, and 2, to implement the COVID-19 data collection app with the training of staff, and also to assess the impact of how the app will impact on timeliness and reporting of data and completeness of data in NCD. My methods, of course, it was carried out here in NCD, the study. The participants were all healthcare workers that were trained as swabbers using the app, and 12 selected active sites here in NCD for swabbing. Data collection was done using user feedback survey questionnaires on COVID-19 collection, the data collection app. There was a pre-post review of the case investigation forms that was reviewed for timeliness and completeness. That is, manually, the case investigation form was reviewed, and then it was compared to the app where an electronic case investigation form was used on the app for entry. So in terms of timeliness, we looked at time as the time of case that was investigated to the time of notification, which I get the report. And in terms of completeness, we defined it as the proportion of fields of the case investigation form that was completed and then compared to the ones that were filled on the app. The time frame, the pre-intervention time frame was from January to February this year. That was when the manual CIFs were looked at and reviewed. Intervention took place in May to June this year. That was when training of staff using the app was done. And post-intervention was from July, where staff were given a survey questionnaire to see how they will use, if the app was for them after training. So the outcomes of that was measures were that we wanted to see healthcare workers' view on how the use of COVID-19 data app collection was, and also to see the proportion of timeliness and completeness of data reporting pre and post intervention. Looking at the results in terms of completeness, as you can see, this bar graph, pre-manually, there was only about 22% was seen complete on the case investigation form when they were filling it manually. Compared to the app, you can see it on the green bar, there's a huge proportion, about 66% was completely filled using the app. In terms of timeliness, using the app, as you can see from the red bar here, you can see it takes about 2 days on average to report back using the manual normal current system reporting for NCD, as compared to the app is almost zero, or the reports come in the same day. So that's another big impact there for the use of the app. What about staff acceptability of using the app? So from the survey, the blue about 4, it's not really showing clearly there. Sorry, I think there's some error on the graph, but about 4 of the participants or the staff that were trained indicated that it was very easy to use, and then followed by 2, which is easy. So basically, we can say that they all found the app very easy to use. So that was the acceptability of using the app. Of course, there were challenges using the app, and the commonest challenge that was faced by the staff during the training was that they were having issues with phone credits, data for connectivity, and also where there's a number of cases that were long on the line for swabbing that they said that time was an issue, but mostly they were referring to data and phone credits for internet support there. So the introduction of the COVID-19 app indicated improvement of reporting COVID data with time and with completeness of data. So this platform of reporting is effective to control any future outbreaks, and as reports can come in timely for timely response. Although there were challenges faced using the app, the end users or the staff found it easy to use. The limitations of this study was that it was a small size sample, which is 12, but which does not represent all the end users of the app. And also looking at the time of the post-intervention, it was short, it was just a month. So then the long-term acceptability of the app could not be determined. So my recommendations, implementations of the app should occur as soon as possible to ensure maximum readiness for future COVID waves. There's option to explore the use of the electronic app to improve surveillance in also other public health conditions. And maybe an option is we could look further to integrate this with the NHIS system. And For my province, I would advocate for funding to implement sustain the rollout of this app in the province. We could look at implementing public health budget annual plan. And of course, we did come up with a policy brief, and my policy brief was given on the table there, as you can see and have a look through. And I will take that back to present to our NCD, SCM and partners. So my acknowledgement for the IT officer who had the brains behind this, but was able to put this app together for me to roll out. And of course to our mentors and Barry and NDOHO team, faculty members, partners, World Vision for actually funding this project for me and my colleagues. Thank you.
We now have the last person of the four, those that we asked to present, Peter to come forward and his presentation. Thank you.
Thank you. Good morning, everyone. Before I begin, I'd like to refer us to the National Health Plan 21-30. So the National Health Plan, the vision of the National Health Plan states that we leave no one behind. And in saying that, we need the communities, government, and partners to work together to bring well-being, health and well-being to everyone. Immunization is one of the greatest investment that have been for health, and to date, many children are unable to access routine vaccinations. The title of this study is improving immunization coverage in underperforming health facilities, and the result of an intervention project in Namanai district, New Island province in 22. We have a bit of introduction here. Effective routine immunization is vital to protect individuals and communities from vaccine-preventable diseases. It aims to reduce child mortality and to set countries to reach global elimination targets of vaccine-preventable diseases. Low immunization coverage increases the probabilities of outbreaks. And for the last 10 years, the immunization coverage has slowly gone down. And in 2014, we experienced a measles outbreak in PNG. We recorded 2,150 cases in 21 out of 22 provinces. Immunization services are delivered through static clinics, mobile and outreach clinics. We have some background information. Global vaccine coverage dropped from 86% in 2019 to 81% in 2021. And in 2019, PNG's coverage for measles for the first dose and pentavalent for the third dose was 34% and 42% respectively. So mobile and outreach clinics can be increased, can increase vaccination uptake, and children in rural areas are less likely to receive all vaccines than children in urban areas. It's 33% versus 49%. It's an indication of poor access and utilization. Increase in immunization coverage also increases with modest level of education and household wealth. During my study in 2019 to 2021, some of the key findings from the study include 47% of health facilities in the district were not conducting mobile and outreach clinics. to remote and hard to reach areas. There was a major breakdown in cold chain system. 55% of the health facilities, so it didn't have a vaccine freeze. And in addition, the low staffing levels and lack of knowledge of new vaccines and vaccine schedules was also evident. So the intervention goals to support mobile and outreach clinics to improve health workers' knowledge on vaccine preventable diseases and the expanded program on immunization. And third one is to improve cold chain and logistics. So I was only able to conduct one intervention, that was to support mobile and outreach clinics in underperforming health facilities. I also advocated for the improvement on cold chain and logistics in the district. And we were fortunate to have UNICEF install all solar fridges in all the health facilities in the district. In selecting the health facilities to carry out mobile outreach, we categorized all the health centers based on their performances. So those that had immunization coverage between 0 and 30%, those were the underperforming health facilities. So we aim to conduct at least 4 sessions of immunization in those health facilities, and then see how they perform. To evaluate this study, we used a comparative analysis of measles vaccine given at 6 months and pentavalent third dose before and after interventions. Study location was at number 9. The study settings, 5 health facilities that did not perform very well. Bawase, Pupuk Health Center, Lamasa, Silur, and Tanga Health Center in number 9 district. All data that were collected were analyzed on Microsoft Excel. This table shows some of the results comparing 2021 data to 2022, August 2022. So we can see there was an increase in there was a change in vaccine coverage from December 2021 to August 2022. For example, in Babase, they had a 10.3 measles vaccine coverage, 10.3%, and then in 2022, after 3 sessions of immunization, it increased to 81.7, and then they had a 71.4 increase. Lamasa, you can see they had 0 all the way. They had only 1 vaccination session, and this data is here to be aggregated and generated through health information system. There's another table here. This is for pentavalent vaccine coverage, third dose for the 5 health facilities. We had a decrease in 2 health facilities. There's Pupuk and Silur. They actually had a stock out of pentavalent vaccines during those times. Discussion. The results of the intervention show that mobile outreach clinics can improve immunization coverage with an improved cold chain system. However, interruption to vaccine and vaccine supplies affect vaccination delivery at the health facilities. Immunization mobile outreach sessions, when combined with other health interventions such as nutrition, dental, and school health programs, will be cost-effective. Some limitations, some immunization data were not aggregated and not included in the report. And all 5 health facilities have not completed their 4 sessions for this year. In saying that, I'm saying that the only way to, not the only way, but the best intervention to improve immunization coverage in Papua New Guinea is to revitalize all mobile and outreach clinics in Papua New Guinea. Thank you. Sorry, I forgot the recommendations. The recommendations is to continue to invest in integrated mobile outreach clinics. And the next steps, the proposed training for health workers and volunteers must proceed as scheduled. Continue to advocate for mobile outreach support because I don't normally work with the family health services in the province. So I have to do my part just to advocate, and thanks to Zoom technology, this recording will be taken as an advocacy tool to the province. So thank you very much.
Thank you. Okay, this now brings to all the presentations of fellows.
So we continue the tradition of the intermediate program with above and beyond in a number of different categories. And we present the certificate to the winner of the different category. We also have some honorable mentions for people who did extremely well, and it was very difficult for the faculty to identify the winners. So we are recognizing a couple of people for each of these different categories. So the first category is the best outbreak investigation. And that goes to Bob Bomai. And Bob investigated a mass methanol poisoning outbreak. It's a very complex outbreak. Unfortunately, there was 17 deaths associated with that. He worked with the police and private industry to investigate that very important outbreak. So fantastic job, Bob. And we have honorable mentions to Brian for a pertussis outbreak, Bernie for pertussis, and Peter for an influenza-like illness outbreak. All exceptional outbreak investigations that were really well written up as well. So the best surveillance system evaluation. This award goes to Symphorium. Symphorium evaluated the ODK platform for the reporting of syndromic surveillance and came up with some fantastic recommendations that the NUH will take on board when looking at syndromic surveillance. We also have honorable mentions to Peter, again, for TB surveillance, and for Maggie Williams for HIV surveillance. Again, wonderful. So well done to Symphorium. Best intervention project. That goes to our presenter, one of our presenters this morning, Rosalind from Bougainville. She did not only one intervention, she did multiple interventions. They were all done with using local resources and all have great potential for scaling and expanding impact. We have honorable mentions for John Landemir and Maggie William as well for their intervention. We have an award for the best policy brief. This was a new addition to our training, which Barry's mentioned. It was a fantastic collaboration with Vital Strategies. And there's an example of the policy brief in the package that we have. Each fellow did a policy brief just like the one that you have an example of. The one you have an example of is our winner, and that's Mary Cavacora. And her policy brief was on improving COVID-19 reporting in NCD, which she also presented to us. We also have honorable mentions for policy briefs, Lekas and Stanley. Well done. And the final award is our Best All-Rounder Award, and that's really in recognition of a fellow who has shown exceptional leadership right throughout the program, has consistently produced high-quality results, and each of the fellows had to produce 5 different reports throughout their training, and the Best All-Rounder goes to Bernie. And congratulations to every fellow. You all did exceptionally well. We started with 30, we finished with 17, and I think that's an indication of how tough this program is. It's not an easy program, and you have all did extremely well through a very challenging period with the pandemic. So well done, everyone.
Thank you. This is the presentation of the certificates and awards.
Thank you, always. Our invited guests, Deputy Secretary, Executive Manager Public Health, our team from the DFAT, WHO. We have the PHAs here with us as senior members of the National Department of Health that are here with us, and our faculty, international faculty, and fellow advanced aFETPNG graduates. Thank you for this opportunity. Firstly, on behalf of the graduates, we have come a long way. We did 2 years and 9 months for this advanced program. We are the pioneers to this program for the PNG aFETPNG. We started with 30, we ended with 17. The program has more than saved us in our respective programs, respective provinces, respective PHs that we are in. We took the challenge within these 2 years, and within the public health programs in the provinces, you're seeing us here representing the other aFETPs, the frontliners, the intermediate, that we are the one that have stood during the outbreaks. The measles outbreak that came on, the polio outbreak that came on, the surveillance systems in the provinces, the disease control programs in the province, and they are all the aFETPs graduates, from frontline to intermediate to the advanced programs. The pandemic that we had, the COVID-19, the surveillance teams in the COVID-19 response, they are all aFETPs. And the first case of polio that was detected in this country, the first case of COVID-19 that was detected in this country is from one of our graduates at this advanced program, and the surveillance system from Morocco that picked up that. So Stewart is not here with us, but he's the person that did the first detection of those 2 outbreaks in the country. So thank you, Stewart and the Morocco PHA team for the active surveillance system that they have. Thank you. With that, we would not have come this far. I would like to take this time to thank our team from the Newcastle and Hunters University for being with us all within these 2 years and 9 months as of this date. Tembury is not here. James, Rachel, Joe, Meg, and the rest of the team that has been supporting the advanced program within these 2 years and 9 months to this level, and then to this day that we have now came out from the advanced program. So we are the pioneers to the advanced program for aFETPNG. We want to see that aFETPNG gets to a new height. Executive Secretary, you are here. Our appeal from this pioneer aFETP, advanced aFETP, we want to see that there is a house, there is a home for PNG aFETP. We want you to house it somewhere that can go a long way for the next generations of aFETPs that will come, and for future of the public health programs for PNG, the Ministry of Health. And we want to see that as you lead the team and get us to the next height as we go. With that, we want to also thank the sponsors, DFAT, Australian government, the WHO for facilitating the program, safety net, new hunters because of university, HSIP, CDC, and of course we want to thank the PHAs, our respective PHAs who stood behind us to release us at this time and the length of this period that we left our own jobs back at our provinces and we had to attend this program. We would like to thank all the PHAs, the CEOs and the management of PHAs in the provinces. So thank you for supporting this program and getting us to up until now that we have now created. Whatever we learn from this, not only for our own benefit, but that will be for the PHAs that will be serving and the people in the provinces that will be serving, so that we make decisions on what is best, and those decisions can make a difference in the health programs that will be running in the provinces. So with that, thank you all, and we wish everyone safe return back to the respective provinces, and our faculty, international faculty that will be going back, and the national faculty that will continue on to move on with this program throughout the course of these interventions. So thank you and God bless us all.
Thank you, Mr. Semborang Shumun, on behalf of the graduates. We'll now come to the closing part of the program, and I'd like to ask Pedro to come forward and make the closing remarks. Thank you.
Okay, I don't have much to say, but because our executive manager is already gone, he's attending another meeting. But because our deputy secretary is unbelievably here, I just have two points to point out. The first one is because we do have a demand for aFETPNG graduates, our primary focus was to train disease control officers, surveillance officers, and we have achieved that, but we also have people who have moved on. So there's always a gap. In this core intermediate, we have, I think, almost 80 to 90% are provincial disease control officers, and therefore we still have to reach out to the districts that Dr. Beer was talking about. We had an issue on faculty because with our support coming from international partners, this will not be there all the time. We are developing our local faculty, and that will take time and as well as resources. We don't have a permanent school. We're using the workforce that we have in the department and as well as the PHA support. There's a lack of uptake by the National Department of Program Managers to support the FET training program and to become facilitators in this program. And I would like to probably get support from the Deputy Secretary and the Executive Manager to some level of maybe soul searching in the public division and have them go through the training program and become faculty members. Unless we do that, I think there's a chance that the program will not be able to sustain itself in the years to come. My wish is that we need to cut down the external support in terms of mentoring. And that can only be done if we have faculty at the national level. Because at the provincial level, they have their own bosses as PHAs, CEOs, and many of those who are becoming now faculty members of the current faculty are senior managers in the PHAs, and we tend to take them up for like 2 weeks and 3 weeks. That's a long time for them, and it can be a problem for their job security as well in the PHS level. So that's the problem I foresee, and that's something that I would like to seek your support as well as Dr. Deer's support to identify people in public health programs at the national level to take ownership and to be part of the FET training and faculty. That's my first sort of remark and probably request. Second is that we need to meet the demand. We need more students, but we don't have the faculty to support their mentoring. Because we don't only mentor during classroom sessions like this. The mentoring continues on while they're doing the fieldwork. And that can be very tough on the students themselves because they're not only just students, they're working people. And they have their own commitment, they have their families. And we need that kind of level of support at the national level, I think. The second is we want to increase the intake, so we need financial support. For the last how many cohorts, I could say 100% of the financial support is external. I would like to see that maybe not 50%, but maybe 10% or somewhere 5% or 20% of the funding should now come from Department of Health or the government of Papua New Guinea. That is something I want to see. But again, I know the kind of situation we are as a state, the financial situation, but that's something that I like to put to you as a deputy secretary. And I've discussed this before with Dr. Beer, but I'd like to also mention that I do put it in the AIP, but I get no money in the AIP, annual activity plan budget. So I like to see maybe a step forward and ownership and owning the program is probably some kind of a budget, allocation. Maybe in a small proportion by year, but eventually we can take over when we are financially okay in this country. At the moment, we're not there. So I think that's my. I think next year we want to increase the numbers. We also will have international participation from Timor-Leste and Vanuatu, but we are mindful that we need to have our own numbers up. This year, I think we have only 9. Next year, we would like to increase the numbers, so we will have a discussion with the faculty, what number we're looking at, because we need to look at the mentoring power with the faculty. So that's just a heads up for the deputy secretary. So when I go and discuss with them after this ceremony is over, then at least I have mentioned it in this in the public forum. With that, I think my closing remark is done.
Us to the end of the program, and the next part of the program is lunch. Yeah.